Introduce yourself first to the audience, then go ahead. You have 10 minutes strictly.
Thank you, sir. I'm just going to switch my video off because of my data consumption, but I'm sure you guys can hear me. My name is Mr. Levin Chetty. I'm actually a PhD student at the University of KwaZulu-Natal. So greetings from Durban and very bright and sunny South Africa. Thank you for joining my presentation today. I will be actually giving a small presentation on physical activity and exercise for older people living with HIV. It's actually a scoping review that we conducted, myself together with my research team. Okay, so let's get started. Aging with HIV has become the latest challenge in the HIV phenomenon as antiretroviral treatment prolongs survival. But the majority of HIV research only includes adults up to the age of 49. With the advent and continual development of antiretroviral therapy, dramatic declines in morbidity and mortality rates associated with the HIV across the globe have been observed. With major medical successes and advances in ART, people with HIV are now living longer. Worldwide, nearly half of those living with HIV are now over the age of 50 years. And by the year 2030, this figure is expected to increase to 70%. In sub-Saharan Africa, which is acknowledged as the epicenter of the burden, 15% of the population living with HIV are aged at least 50 years and older. Predictive modeling suggests that by the year 2040, this ratio will increase to 27%. This means that the number of older people living with HIV in sub-Saharan Africa will have increased to 9.1 million people. While antiretroviral therapy has increased life expectancy in people living with HIV, it is unfortunately also associated with a constellation of health problems and physical or functional impairments. Simply stated, older people living with HIV are now living longer, but they are at greater risk for developing various health complications. The role of regular exercise in older HIV-negative populations has been extensively researched. We know that for a fact. Improved cardiovascular and neuropsychological health and decreased rates of osteoporosis and osteoarthritis, together with the lower risk of diabetes, are just some of the associated benefits. Although general exercise guidelines exist for younger populations living with HIV, there are no clear guidelines for prescribing exercise for older people living with HIV, especially those who are 50 years of age and older. The aim of our study, therefore, was to map the existing literature on the effects of exercise and physical activity prescriptions for older people living with HIV. So what did we actually do in our methodology? We conducted a scoping review using the methodological framework proposed by the Joanna Briggs Institute for Scoping Reviews. In line with this framework approach, the following 5 steps were used to conduct the scoping review. 1, identification of the research question. 2, identification of the relevant studies. 3, selection of eligible research articles. 4, extraction and charting of the data. And lastly, but not least, number 5, we collated, summarized, and reported the results. This figure in slide 6 actually represents the preferred reporting items for systematic reviews and meta-analysis flow diagram. This actually depicts the process of searching and selecting the research publications. As you can see, an electronic search for literature was conducted on the following 5 databases: PubMed, Google Scholar, CNAL, Medline, and Cochrane Library. This was done using the population concept context model to formulate a string of keywords in alignment with our primary research question. Initially, 349 articles were identified through a database search. Following a rigorous abstract and screening phase, 15 published research articles were finally selected for review and analysis. The selected articles were further assessed in greater depth to ensure that they included a measurement or focused on specific dimensions of physical activity and exercise, in accordance with the study's inclusion and exclusion criteria. Based on the main objectives underpinning this review, the 15 selected articles were contextualized in relation to the following 3 research domains. Firstly, the physical health-related outcomes of exercise in older people living with HIV. Secondly, the mental health-related outcomes of exercise in older people living with HIV. And thirdly, the impact of exercise on functional status levels in older people living with HIV. The review and analysis of the selected studies suggests that performing aerobic exercise or a combination of constant aerobic and progressive resistance exercise may lead to significant improvements in measurements of cardiorespiratory fitness, strength, and psychological outcomes in older people living with HIV. Results for the cardiorespiratory status indicated improvements in VO2 max measurements in aerobic exercise participants compared to their non-exercising participants also improved. Similar improvements were also observed in combined aerobic resistance exercises compared to their non-exercising counterparts. Significant improvements in upper and lower body strength, as well as balance, flexibility, and ambulatory function were also observed in studies that employed a combination of aerobic and progressive resistance training. This suggests that combined aerobic resistance training may be ideal to maximize both the cardiovascular and strength benefits in this population. The results for psychological status demonstrated significant improvements in depressive symptoms, mental health, and overall everyday functioning, and also quality of life. In fact, this review actually observed that the neurocognitive domain of executive functioning may be the domain that most benefited from physical activity and exercise. In conclusion, we actually found that the scope and review showed that exercise is a promising approach that is both an effective and safe treatment option for older people living with HIV. It has the capacity to confer a number of physical, psychological, and quality of life benefits on participants in these programs. With increased life expectancy due to ART in both the developed and the developing world, it is crucial that a range of alternative rehabilitation options, including physical activity and exercise, be made available to older people living with HIV. However, we were concerned that only 3 out of the 15 studies were conducted in the developing world. Of even more concern was the fact that there were no studies conducted in sub-Saharan Africa, the region with by far the highest HIV burden. We therefore now believe that it is vital for evidence in this field to focus on the specific challenges faced by older people living with HIV in resource-poor African countries. Thank you for listening. That's the end of my presentation. Thank you.
Excellent. Thank you very much for sticking to time, Chetty. You have set the standard here. And
thank you.
I would encourage our next presenters to do the same. Meanwhile, let me just ask the attendees that if you have any questions, please use the question and answer icon at the bottom, and we'll be answering you, or the presenters will be answering you as we go. So again, the presenters, please, you can be answering the questions as we go. So let's have our next presentation. And this is from Sarah Olabode from Nigeria. Could you please load your presentation, Sarah? And just introduce yourself quickly before for the audience. Please share your presentation, Sarah.
Professor Kamiza.
Welcome, Mamudo.
Problem in logging in. I'll be just watching from here. Okay.
Okay.
Okay, good afternoon. Moderator, Mr. Moderator.
Okay, Mamudo, we hear you. Can we hear the presentation, Sarah, now?
Okay, thank you. Yes, good afternoon. Please permit me to stand on existing protocol. I wish to thank the organizers of this symposium for allowing me to present this paper. My name is Sikiru John-Olabode. I'm a hematologist and a senior lecturer in the College of Medicine, in the Department of Hematology and Blood Transfusion, College of Medicine, University of Lagos. And today I'll be presenting a paper titled The Prevalence of prothrombin gene mutation and factor V gene mutation among pregnant women, the experience from a multi-center study in Nigeria. As regards disclosure, this paper has already been published in the Journal of Blood Medicine and it's available on PubMed. By the way of background, pregnant women with inherited thrombophilia have over 50% increased risk for developing venous thromboembolism. In layman's language, venous thromboembolism simply means increased formation of blood clots within the body. And inherited thrombophilia means these are individuals that have a genetic predisposition to forming blood clots within their body. So what this means is that people that have this genetic predisposition have an increased risk, especially women, have an increased risk of 50% of forming blood clots in pregnancy. Venous thromboembolism has been attributed to 9 to 14% of maternal deaths. And venous thromboembolism, also known as VTE, has been linked to inherited thrombophilia. And both have been linked to adverse pregnancy outcomes like preeclampsia, stillbirth, intrauterine fetal death, and increased fetal morbidity and mortality. The most frequent inherited thrombophilia are prothrombin gene mutation, also known as factor II. Prothrombin is also known as factor II, so factor II gene mutation, and factor V gene mutation, which is also known as factor V leading mutation. Studies have shown that the prevalence of these two mutations are about 3 to 15% in Caucasians, but it's assumed to be rare in other ethnic populations, including in Africa. Found out this was what got us interested in this study, that we don't have that much data about the inheritance of these two genes. We want to know about them, how it pertains to the pregnant women in Nigeria, in a country where we have the largest proportion of burden of maternal mortality in sub-Saharan Africa. We need to know, do we have this gene mutation in our pregnant women, and what's the impact on pregnancy outcome? So our aim was to determine the prevalence and distribution of factor V leading mutation and factor II mutation in pregnant women in Lagos State, Nigeria. This study was carried out over a period of 13 months in two centers, Lagos University Teaching Hospital, which is a tertiary institution, and Randall General Hospital, a secondary health institution in Lagos State. 400 women were examined for this study. These two hospitals together have over 1,000 beds available for patients, and per calendar month, they see over 1,000 pregnant women. Our study participants were eligible women, which are pregnant women between the ages of 15 to 49 years. Women less than 18 years were regarded as emancipated minors. Our genotyping was done in the Nigerian Institute of Medical Research using the BioRad PCR detection system. We had as our controls for the procedure gene fragments manufactured by Integrated DNA Technologies. And our data was analyzed using Stata 15. So our result, what did we get? So this table shows the characteristics of our study participants. The mean age for our pregnant women was 31.9 years. The median gestational age was 20 weeks. Over 3/4 of our study participants were multigravida. These are women that have had at least 2 pregnancies. And we had the Yoruba, over half of our study participants were women from the Yoruba ethnic group. This will be expected because we carried out this study in Southwest Nigeria, where we have a high population of, we have majorly the Yoruba ethnic group. So of the 400 participants that was recruited, 397 and 389 samples were successfully amplified for factor 5 Leiden mutation and factor 2 mutation, respectively. The key finding in our study was that factor 5 Leiden and factor 2 mutation prevalence is actually very low. So that means the amount of pregnant women that had this mutation in this study was actually very, very low. In fact, for factor 2 mutation, none of the study participants had the genetic mutation. But for factor 5 Leiden mutation, we had 3 participants that had heterozygous mutation. This figure is just trying to show us the distribution of the normal genotype and the mutant genotype in our study population. Like I earlier mentioned, factor 2 mutation was not seen in any of the study participants, whereas for factor 5 Leiden mutation, 3 of the study participants had heterozygous mutation. So looking at the genotype frequencies, for factor 2, we did not observe any mutation, no heterozygous mutation, nor did we see any homozygous mutation for factor 2, for the factor 2 gene, but for factor 5 Leiden mutation, we observed the frequency of our observation was just 1%. So this genotype frequency, it points to the fact that the Weinberg equilibrium is maintained in this population. From our conclusion, our data revealed a very low prevalence of factor 5 Leiden mutation and factor 2 mutation among pregnant women in Lagos, and also suggests that screening for factor 5 Leiden mutation and prothrombin gene mutation in pregnancy might not be of any clinical significance among Nigerian women. However, carrying out a genome-wide associated study is recommended to determine the true impact of these 2 common inherited thrombophilias in our population. This study was sponsored by the Fogati International Center of the NIH. I wish to acknowledge all my co-authors, most especially my mentors, Professor A. Sakomo and Professor A. Oshuntoki. This is a list of some of the references used in our study. Thank you for listening.
Thank you very much, Sarah, for that great presentation, and again for keeping to time. Please be available in case people ask questions, and again to the audience, you can direct your questions on the question and answer group icon, which the presenters will be able to access and answer you. Thank you very much. Let's have our next presenter, who is Sikiru Usman. Introduce yourself, please, and also load your presentation.
Good afternoon, everyone.
Afternoon.
Yeah. I'm Sikiru Olatunji Usman from the Department of Pharmacology, University of Lagos. The title of my presentation is Evaluation of the Effects of atazanavir-ritonavir on the pharmacokinetics and toxicity of lumefantrine in patients living with HIV in Lagos University Teaching Hospital, Southwestern Nigeria. Atazanavir-ritonavir-based antiretroviral therapy and artemether lumefantrine are commonly used drugs in the management of HIV infection and malaria comorbidities. However, clinically significant drug interaction may occur when these drugs are administered concomitantly as a result of the interaction of artemether lumefantrine and atazanavir-ritonavir with cytochrome P3A4 enzyme and QTZ interval. Therefore, the study was aimed at evaluating the effects of atazanavir-ritonavir on the pharmacokinetics and toxicities of lumefantrine, which to our knowledge had not been previously reported. In a case control study, 20 participants having Plasmodium falciparum malaria were recruited and divided into two groups, namely atazanavir-ritonavir arm and control arm. The atazanavir-ritonavir arm consisted of participants of patients living with HIV who had been stabilized on atazanavir-ritonavir-based antiretroviral regimen, while the control arm consisted of non-HIV infected participants. All the participants were administered 6 oral doses of artemether lumefantrine 80/80 mg at recommended intervals. Thereafter, their blood samples were collected at different time intervals over 7 days. The concentration of lumefantrine in each sample was quantified with high-performance liquid chromatography and used to determine its pharmacokinetic parameters, which were compared between the test and control groups. To evaluate toxicity, electrocardiography, adverse events monitoring, and blood tests were also carried out at pre and post doses of artemether lumefantrine. Table 1A and the next table depicts the demographic data and baseline data of the participants. And it shows that there were no significant difference in the baseline parameter. And this shows that the participants in both arms of study were well matched. Table 2 depicts the PK parameters of lumefantrine. It shows that atazanavir-ritonavir increased by approximately 50% the area under the plasma concentration time curve of lumefantrine. It also increases significantly the day 7 concentration and half-life of lumefantrine. All this significant increase in the plasma concentration of lumefantrine may not be unrelated to the inhibitory effect of atazanavir-ritonavir, which is beneficial because it will increase the inhibitor completely which malaria. Figure 1 also depicts similar results. The plasma concentration of lumefantrine is increased as indicated by the blue curve in the atazanavir-ritonavir arm, except at the initial stage, which may be due to malabsorption that are usually experienced in HIV infection, which may be caused by gastrointestinal pathology and enteropathy. Figure 2 depicts the results of the QTC interval at pre and post doses of artemether lumefantrine. And it shows that in the atazanavir-ritonavir arm, there is a significant increase in the QTC interval in the participants in the atazanavir-ritonavir arm. And this is an indication that combination or concomitant administration of atazanavir-ritonavir-based regimen and artemether lumefantrine is potentially cardiotoxic. Potential because the values obtained were still within normal range, but we observe significant increase in the atazanavir-ritonavir arm as against the control arm. And the potential cardiotoxicity may also be related to the increase in QTC interval, the effects of atazanavir-ritonavir and the artemether, which are known to prolong QTC interval. So this may produce additive QTC interval prolongation. Table 3 depicts the results on liver enzymes and creatinine and hemoglobin level. There were no significant increase in the liver enzymes, creatinine, nor hemoglobin level. And this means that the interaction is not associated with clinically significant hepatotoxicity, kidney toxicity, nor blood toxicity. The adverse events reported were also few and mild, but it is important to note that chest pain and body weakness, which are symptoms of cardiotoxicity, were observed only in the atazanavir-ritonavir arm at the post-dose of artemether lumefantrine, indicating or corroborating the potential cardiotoxicity effect of the interaction. In conclusion, atazanavir-ritonavir increased the drug exposure, which is the AUC, and the 7 plasma concentration of lumefantrine. Artemether lumefantrine is therefore considered effective for the treatment of malaria in patients on atazanavir-ritonavir-based regimen. Concomitant administration of artemether lumefantrine with atazanavir-ritonavir-based antiretroviral therapy is not associated with any clinically significant renal, blood, or liver toxicities. However, the combination is potentially cardiotoxic. Therefore, caution must be exercised when administering the drugs concurrently. I would like to quickly acknowledge BRAINS, which financed the project through a mentor research grant from NIH. Thank you for listening.
Wonderful. Thank you very much, Sikiru Usman, for the good presentation and those significant findings. And again, audience, you can use the Q&A icon on the bottom to answer, to ask Sikiru any questions you may have. We are still sticking to time, which is very good. Our next presenter is Shelley Wall, talking about amputations secondary to burn injuries in a resource-limited setting. Shelley, please load your presentation and introduce yourself.
It's not letting me share my screen. Oh, there we go. Thank you. Oh.
Sikiru, you can come out of your video.
Sorry, I'm just struggling to share my screen. Give me a second. Okay, can you see my screen? Sorry, I've just had trouble.
Yes, we can.
Okay.
You can also share your video, Shelley, if you want.
Sure, give me a second. Okay, good afternoon, everyone. My name is Shelley Wall, and I'm a general surgeon. I'm a burn surgeon at the Pietermaritzburg Burn Service in Pietermaritzburg, South Africa. Today, I'm going to be speaking about amputation secondary to burn injuries in a resource-limited setting. So just a bit of background, over 1 million people on the African continent sustain burns every year. And this accounts for 18% of hospital admissions and 6 to 10% mortality rate. They also account for a loss of 18 million daily disability-adjusted life years worldwide, and Africa shoulders 2/3 of this burden. Amputations are a devastating consequence of severe burns. And in a resource-limited setting with a large burden of burns, the main emphasis is on acute management and not rehabilitation. Amputations in these settings can be exceptionally challenging as the rehab services are inconsistent and often fragmented. An amputation is not exclusively a loss of a limb. It can result in disability, loss of quality of life, joblessness, mental health issues, loss of sense of self, and body image issues as well. In resource-limited settings where often the majority of our workforce is manual labor, appropriate or inappropriate rehabilitation often has significant consequences. And unfortunately, the demand for appropriately trained rehab therapists far outweighs the supply. In fiscally restrained settings, only the most severely disabled patients are often offered rehabilitation to try and get them to some form or some semblance of independence. Whereas those that are less disabled are often, there's no focus on rehabilitating these patients to try and introduce them to the employable population. A study done in India demonstrated that 82% of lower limb amputees lost their jobs as a direct result of their amputation. There is increasing acknowledgement that quality of life is an important outcome for rehabilitation programs. And amputations have a significant effect on quality of life for years after the event. Phantom limb pain affects quality of life in terms of restricting limb mobility, and it also has a negative psychological effect on the patient. Employment status seems to be a problem with quality of life for developing countries more than developed countries. And this is probably due to better financial support of patients in developed countries and developing countries. So the study that we did aimed to analyze the amputation secondary to burn injuries. We wish to identify vulnerable groups to inform advocacy efforts to reduce the devastation of these amputations and to target efforts to prevent burns in these groups of patients. We wanted to highlight the burden of these injuries on the healthcare system and to emphasize the need for additional trained rehab therapists. The Pietermaritzburg Burn Service is set in Pietermaritzburg, but it's run by 2 burn surgeons. We have 40 beds across 2 different hospitals, the tertiary hospital and the regional hospital. Annually, we manage between 400 to 450 patients as inpatients and another 500 patients as outpatients exclusively. And we support 19 districts and a population of 4.5 million patients. The study that we did was a retrospective database review of an existing burns database, and all burns patients that were admitted requiring amputation between the 1st of February 2016 to the 31st of January 2019 were included. And inclusion criteria included both pediatric and adult patients, and as I said, patients with amputation secondary to a burn. The demographic variables we looked at were these. And in terms of amputation variables, we looked at the limb involved, so whether it was the upper limb or the lower limb, the side of the amputation, the level of the amputation, and whether an escharotomy was performed or not. Outcomes, we looked at the number of septic episodes, the length of stay, and the mortality. Statistical analysis was done with RStudio. And the total number of burns admissions in the study period was 1,575 patients. And 44% of these were pediatric patients, and pediatric patients were considered to be children from 12 years and under. And the total incidence of amputations in the total burn population was 3%. However, breaking it down into pediatric and adults, the pediatric rate was 1.5% and the adult rate was 4.8%. 48 patients then met the criteria, the inclusion criteria. In both the pediatric and the adult amputation groups, males predominated. There was a significant difference in terms of the mechanism of injury between the 2 groups. More than 2/3 of the amputations resulted from electrical injuries in the pediatric group, whereas the adult population was most likely to be due to flame. In accordance with that, there was a significant difference in terms of energy source between the two groups, with low voltage electrical burns predominating in the peds group, and the adults, it was mainly wood was the main energy source. Children, it was mainly accidental burns, and convulsions were the leading cause of burns, then subsequent amputations in the adult group. In the study population, upper limbs were significantly more common than lower limb amputations, and right-sided upper limb amputations distal to the wrist dominated in the pediatric group. The difference between upper and lower limb amputations in adults was negligible. Adults were more likely to need bilateral amputations, and they were also significantly more likely to have had sclerotomies. In terms of outcome, there wasn't much difference in terms of sepsis and length of stay or difference between the two groups, but the pediatric group had no mortalities, whereas the adult group had an 11% mortality rate. However, in terms of the average stay that our patients in the whole, for our total burn population, the average length of stay for all of our patients is 1.7 days per percent burn. And the patients who had undergone an amputation, the average length of stay for them was 27 days per percent burn. The decision to amputate a limb is never an easy decision. The impact of an amputation on a patient in terms of cultural belief, reintegration into the community, return to work, and loss of future income is immense. The community that the Pietermaritzburg Burn Service serves is steeped in Zulu cultural belief, which includes the need to remain intact to become an ancestor after death, traditional healing as a means of cure, and the role of cultural hierarchy in decision-making. There's also fear of being excluded from the community after an amputation, and the decision to perform an amputation following a burn injury cannot be made lightly. There's a discrepancy in the literature in terms of mechanism of injury for amputations. In high-income countries, it's predominantly high-voltage electrical injuries resulting in amputation, whereas this study that we did, it aligns more with other studies done in Africa, where the most common injury resulting in amputation is from flame burns. They are often most commonly associated with epileptic patients as well. Epileptics are a particularly vulnerable group when it comes to requiring amputations following a burn, and this is even more challenging in a resource-limited setting. The prevalence of epilepsy in low middle income countries is high, with Africa shouldering the 20% of the global burden of epilepsy. And often it's left untreated in resource-limited settings. And this is due to poor communication between the healthcare provider and the patient, lack of societal support for these patients, and limited financial resources. Is 13.8 per thousand, and only 14.7% of these patients regularly take anti-epileptic treatment. Another sub-Saharan study showed that 13% of South Africans use electricity for cooking, and 60% of South Africans burn firewood or charcoal for cooking. It has also been demonstrated that fire can be a photostimulator for epilepsy as well. So in a country where fires are used by many people for heating and for cooking, it's virtually impossible for epileptics to avoid fires. Wagner et al. Showed that 93% of patients with active convulsive epilepsy, even in rural South Africa, have previously been told that they have epilepsy. 64% of these patients have reported being on treatment at some point in time, although it may not be consistent. So it shows that there's not a gap in diagnosis, but there is a gap in treatment. Barriers to these patients accessing care include cultural beliefs surrounding epilepsy, financial constraints, and the availability of medication. So in terms of financial constraints, the patient actually getting to the clinic to get their medication, but also the availability, so the Department of Health providing the medication to the patients. Anecdotally, many of our patients reported having gone to the clinic to fetch their medication, but the medication being out of stock at the clinic. So Wagner et al. Study demonstrated that there's a need for education initiatives to inform the patients, or to rather empower patients with knowledge about their diagnosis and management, to address potential cultural concerns regarding epilepsy, and also to drive home the importance of adherence to anti-epileptic medication. And this may be a good first step in improving compliance to anti-epileptic medication. The pediatric population, the upper limb amputations were most common. And more than half of these amputations were distal to the metacarpophalangeal joint. So most of them were finger amputations. And this is unsurprising considering the mechanism of injury. So these are children that are grabbing live wires with their hands and placing their fingers into electrical sockets. The right side dominance was because the mean age of these patients was 7, and by then they will have established hand dominance. And if they'd grabbed the wires with their dominant hand, that explains the right predominance. Increasingly high electricity tariffs has resulted in increase in the number of illegal electrical connections in informal settlements and townships. These illegal connections bypass the municipality electrical meters and often result in live wires being exposed, often on the ground at the level that children play at. And these place children at risk for electrocution or electrical injury. A large discrepancy in the length of stay exists between the patients not requiring amputation and those requiring amputation. And this is because, well, firstly, because the patients who require amputation often just have worse burns, so they have more severe burns. But also it's in part due to the patient requiring intensive rehabilitation. There's a shortage of rehabilitation therapists, and these patients then stay longer for rehab so that they can actually get the appropriate rehabilitation. More trained therapists at a district or a clinic level would alleviate the burden of rehabilitation on the beds in the regional and the tertiary hospital. So we could discharge these patients earlier to have rehab at their district level, and this would then relieve beds for patients who need amputation, or who need surgery that is not possible at the district hospitals. So in conclusion, the incidence of amputations in burns is low.
Summarize.
Sure. It remains a devastating morbidity. Epileptics are a vulnerable group and education interventions are needed. Advocacy efforts are needed to ensure constant supply of these anti-epileptics. Children electric injuries are more likely to cause amputation. Communities need to be informed of the risks of illegal connections, and initiatives are needed to drive safe provision of electricity to underprivileged, vulnerable communities. Thank you.
Thank you very much, Shelley. A little extended over time, but that's okay. It's just a minute or two. Thank you very much for that great presentation. Let's get our next presenter, who is Muhammad Garba, talking about the relationship between health insurance and self-reported quality of life among hypertensive patients in Nigeria. Please load your presentation.
Okay, good afternoon, sir. Good afternoon, participants.
Good afternoon.
Okay, thank you, sir. Thank you to the according me this opportunity of presenting findings of our work. My name is Dr. Muhammad Bello Garba from Mamudo University, Zaria, Nigeria. I will be presenting a work on relationship between health insurance and self-reported quality of life among hypertensive patients in Kaduna State Northwestern Nigeria. And I will follow this outline, give a background and objectives of the study, the methods we use, results, conclusion, references, and acknowledgements. Despite the fact that the threats from communicable diseases is persistent in sub-Saharan Africa, the rising burden of non-communicable diseases pose a great challenge to attaining sustainable development goals in these countries. And notable among the major presentation of this epidemiological transition is the fact that these NCDs require prolonged and usually expensive care among the predominantly poor populace. And this is shown to be associated with poor utilization of essential services, incurring catastrophic health expenditure and low quality of life among the patients and their immediate families. In these countries of recent, social insurance schemes are introduced to remove financial barrier to care, and by this, improve the outcome of care among the populace. There are evidence linking insurance coverage with significant increase in access to care and improvement in self-reported quality of care. In Nigeria, National Health Insurance Scheme was introduced in 2005, and more than 15 years after then, there are limited evidence about how it has impacted in the outcome of care and the quality of life of its enrollees. Therefore, this study compared self-reported quality of care among the health insured and uninsured hypertensive patients in Kaduna State, Nigeria. Our methods, we conducted this study in Kaduna State, one of the 36 in the Federation and located in the Northwest geopolitical zone, with a projected population of over 8 million based on 2005 population census. We use cross-sectional comparative study design, and our study population includes adult hypertensive patient assessing care in 5 secondary and tertiary health facilities in the state. We determine a minimal sample size of 304 for each comparative group, using 95 confidence interval, a power of 8%, considering 10% no response rates, and then a proportion of insured and uninsured patients reporting ability to do their daily activities without difficulty, as reported by a previous study in Kwara State or Central Nigeria. We use 2-stage stratified sampling technique to select our study participants. The first stage is to select 3 secondary and 2 tertiary health facilities from a total of 8 and 4 public facilities accredited for service provision under the scheme. And then in each of the selected facilities, hypertensive clients were stratified into insured and uninsured, and the minimum sample size were recruited using systematic sampling technique. We use a semi-structured interview administered questionnaire adapted from McGill Quality of Life questionnaire SF 336 version 2. And then these tools were pre-tested in a neighboring state. The tool was used to assess patient ability to conduct usual activities as well as emotional and social state of mind. Data was collected by 6 trained research assistants using smartphones on ODK version 3. And then submission was made online on a domain specifically created for this work on COBOL data toolbox. Daily submissions by the research assistants were checked electronically on the COBOL toolbox dashboard for completeness, and then it was finally downloaded and analyzed using SPSS version 23. Clients' ability to conduct usual activities, emotional and social states were measured and scored on a scale of 1 to 5. For physical component, the ability to conduct usual activities, and the emotional components asks things bordering around feelings about the future in relation to the disease outcome, and then the social concerning the patient views about the value of life in the future. For each of these domains, mean scores of the 3 components were compared between the 2 groups using independent t-test, independent sample t-test. But then comparison within the group, that is at the time of data collection and at the same time preceding year, was compared using paired t-test. Statistical significance was set as alpha level of 0.05. Ethical approval was obtained for this work from the Research and Ethical Committee of the State Ministry of Health for the secondary facilities, and for the tertiary facility, the RAVs of the teaching hospitals. Informed written consent was obtained from the participants before recruitment to the study, and the data collected was stored in an encrypted passworded personal computer of the principal investigator, and then each participant's records were de-identified before storage. We found out that the participants among insureds uninsured are about 7 years older than the insureds, with a mean age of 57 compared to 49. And then higher proportion of insured patients had formal education and were involved in a formal employment sector compared to their counterparts among the uninsured. The aggregate quality of life, self-reported quality of life, showed that there is no significant difference in the overall score between the insured and uninsured. However, more uninsured, higher proportion, about 1/3 of them reported incurring catastrophic expenditure due to hypertension, compared to just 9.7% of the hypertension of the insured clients. However, comparing the same periods with the assessment of the clients about the same period in the preceding year, both insured and uninsured reported an improvement in overall quality of life. Now, if we look at the different components of the self-reported quality of life, compared to the same time the preceding year, we look at the two groups reporting significant improvement in physical quality of life. If we look at the results, the p-value is significant for these two groups. And then higher proportion of the uninsured client reported disturbance in their mental state of life, with more insured patients showing that there are some improvements compared to their score in the preceding year, and the p-value shows that the difference is statistically significant. Now, concerning the social components, there is no any difference in the two comparative groups when the value is compared. Now, in conclusion, our study found out that insurance status is significantly associated with protection from financial risk due to care for hypertension. And then there is also significant association between insurance status and mental component of self-reported quality of life, but not social and physical. From the findings of the study, we recommend for an expansion of National Health Insurance Scheme so that the team of population will get the benefit from what it offers in financial risk protection and improvement in mental quality of life, and then in improving the life of the enrollees. This is the reference of the work we use for the study. And then we want to acknowledge the support we got from Stamina, which is a support of training and mentoring in Nigeria for academics, sponsored by Fogarty International Center of the US National Institute of Health, which funded this study. And then my research mentors, Professor Clara El Jambi and Dr. Moawe Babel Sufyan, both of Ahmadu Bello University Zaria, and the principal investigator of the program, Professor Sagai of Jos, and Professor Mokhtar of Zaria. Thank you for listening.
Thank you very much, Muhammad. That's another wonderful presentation, and it's been on time. And again, encourage the attendees to ask questions in the Q&A. The presenters will be answering you as we go. Lastly, but not least, we have Kozia Ziambo, who is going to present about evaluation of TB and HIV service delivery telementoring program in Zambia. I suppose it says Zambia there. So please load your presentation, Kozia, for the audience to follow.
Hello, Stephen. It looks like Kozia is not on the webinar. So we might want to probably go ahead with the Q&A session or something like that.
Right. Okay. Okay, that's fine. I mean, what he has given us 10 minutes of questions and answers. So please go ahead. I must say that all these have been great presentations and precise, sticking to time, which we must appreciate the presenters. So, any questions? whilst we are preparing for questions, the technical moderators want to take a picture for all of us. So I would like to ask all of us to start our videos so that the pictures can be taken. Unmute the videos, please. Some are still unmuted. Sarah, there's Muhammad, there's Sikiru. Just unmute the video.
All right.
The technical moderators,
Yep,
have you done?
you.
Are you
Yeah,
done?
we're done.
You are done. Thank you very much. So you can mute back the videos, and you can ask questions. Then I can verbally refer them to the presenters, who should be able to give you a verbal answer. Now we still have some time. So seems we don't have questions from the audience. Let's see. Sikiru, that's now my question to Sikiru. The toxicity, we are talking about the cardiotoxicity. It's something serious. Has something been done to alert the authorities so that they can look at this and quickly act on it? It seems Sikiru cannot hear me, or okay, but I can see him. The more technical moderators, is Sikiru muted? Can you unmute?
Yes, sir. I have done that, sir.
Okay. Sikiru? I can't hear from my side. I don't know whether.
Maybe you repeat the question for him, please.
Okay. Sikiru, the question is, I've seen your study looked at the cardiotoxicity in these HIV drugs. I suppose these are still being prescribed now. Now, with these findings on your research, has anything been done to alert authorities or on this potential risk?
Okay, I think I understand the question. The results shows that the QTC interval that were observed, the significant increase in the atazanavir-ritonavir harm, they were within normal range. So we could not say specifically that the interaction produced cardiotoxicity effects. So we could only say it's potentially, the interaction is potentially cardiotoxic, because the significant increase in the QTC interval in the atazanavir-ritonavir harm was not observed in the control arm. But the fact that despite the significant increase, it was still, the value was still within normal range. So this is why we say it is potentially cardiotoxic, and we could only advise that when the drugs are to be administered concomitantly, caution should be exercised.
Okay. Yeah, it's clear now. There's a question in the question and answer from Dr. AGBO. It says it says what type of physical activity, this is going to Levin Chetty, what type of physical activity and exercise do you suggest for this group, the elderly group, considering the higher prevalence of other comorbid states in them? Do you suggest we give advice older persons to indulge in this? Levin, if you have heard it, you may want to answer it. What type of activities are you recommending for this group?
Yeah, thank you, Dr. Agbo, for that question. It's quite relevant. I think the first thing we need to actually understand is from the review that we've currently done, we need to understand that exercise for this population is safe. I think that's an important factor. Secondly, when it comes to what type of exercise, for most of the literature that we're reading out now, or we're going through now at the moment, there's a combination of aerobic and progressive exercise seems to be the most beneficial. So I would actually suggest a combination of progressive resistance exercise together with aerobic activity. However, what we're exploring at the moment is the dosage of exercise. What limits, what time limits do we impose on this population? I think it would be interesting to see what those results will be like. Thank you.
Thank you very much. As a follow-up, I mean, this age group, they are prone to fractures, osteoporosis. Now, these weightlifting exercises, are we not putting them at risk of breaking their back, legs?
Yeah, point taken, but I think we'll have to look at also volume and intensity of activity. We can go via the ACSM norms, which currently recommends 20 minutes a day of light to moderate activity. So we're not going to actually advise anything that falls into the high intensity level. It's more your low to moderate activity types.
Understood. Understood. Let's see if we have any other questions. I think there's none in the box, but I have a question to Sarah. Sarah, the study you did looking at thrombotic events in pregnant women, but at the end of it, you found that actually the women in Nigeria are not vulnerable. Did you clinically see these thrombotic events that encouraged you to do this study?
Hello, sir. Thank you for the question, sir. If you can hear me. Hello, can you hear me, sir?
Yes, we can hear you. We can hear you.
Yeah, thank you for the question, sir. Yes, we looked at these two coagulation factors, factor 2 and factor 5. For factor 2, we saw that the gene, we didn't see any mutation in our study participants. So, but for factor 5 gene, we got 3 participants that had heterozygous mutation, meaning they had one normal allele and a mutant allele. So we followed up these 3 participants, and their pregnancy was uneventful, delivery was uneventful, and postpartum period was uneventful. And this largely supported previous studies that has shown that though some pregnant women do have inherited thrombophilia, but some of them do undergo normal pregnancy without any thromboembolic episode. So I guess such was the case of our 3 participants. They did not have any thromboembolic episode. in the index pregnancy and also no previous history of thromboembolic episodes.
Okay. Thank you very much. That's clear. Again, we have now reached the end of our seminar. I would like to thank all the presenters for the great presentations, which were sticking to time, and I wish you all the best. And maybe a few words from my colleague, co-moderator, Dr. Ismail. Anyways, Dr. Ismail.
Okay, Dr. Kamiza, hello, can you hear me?
Hello, yes. Yes, I can hear you.
Few I'd like just to emphasize. I will not go to ask anything because you covered very well the key notes when you put some issues to the Palestinians. Just I'd like to emphasize that the presentations today just had some very common issues. This is the quality of life that is desired in all these presentations. Let's see the hypertension and the insurance, the problems of epilepsy and the thrombotic episodes, and a few related with COVID and maternal mortality and things like that. So this just gives us a very good approach, and the thematics about these breakouts, I think, achieved a very high quality and high profile. For me, I'm very happy, and I would say just congratulations to all speakers. Thank you.
Thank you very much for that summary. At this point, then, probably, I don't know whether the moderators have anything to say, or we close off as it is.
Nothing to say at this time. I think we close off.
Okay. Thank you very much. Thank you all. Have a nice day.
Namana